Okay. In the previous class, I had discussed about acute kidney injury, and in this, we will discuss about chronic kidney disease. Okay, like acute kidney injury, the chronic disease. Hold on. Okay. So, what is chronic kidney disease? It is actually a progressive decline in the glomerular filtration rate. So, the glomerulus, all that kidney basically the filters the fluid through the glomerulus around 120 ml per minute. This is the amount of GFR normally. Hmm. In CKD, there is a progressive decline in this quantity actually. Basically, there is a progressive decline in the glomerular filtration rate over the span of longer time. Unlike in acute kidney injury, where things happen more or less abruptly, whereas in chronic kidney disease, it is a progressive decline. And this progression is linked with the GFR with the amount of albuminuria. So the uh, albumin is excreted in the urine. Okay. Normally, the albumin excretion in the urine is almost not there. If the albumin is excreted in the urine, that is a sign of there is a CKD. There is a chronic kidney disease. In fact, we use albumin quantity of the albumin excretion. We use it as a marker of kidney disease. The more the albumin being found in the urine, it suggests there is a more amount of kidney damage. So basically, in the patients with diabetes, we check amount of albumin present in the urine. If the amount of albumin present in the urine is almost nil, then it is a good sign. If the albumin present is detectable, there is in fact a microglobinuria, microalbuminuria it is. Microalbuminuria. I'll come to that. When it is called as microalbuminuria, when it is called macroalbuminuria and all that, I'll come to that. So the kidney function, the progress in a CKD, there is a albuminuria is there in the urine. That's what is important here. Then, what is end-stage renal disease? Accumulation of toxins and fluid and electrolytes which are normally excreted by the kidneys, which leads to death unless the toxins are removed. That means there is a progressive accumulation of toxins in the blood. These toxins are they reach such a level that if it is not removed from the blood, either by dialysis or transplantation, the patient will die. Then you said to have end stage renal disease. It is a stage in the CKD because it starts with a milder disease, progresses to severe, then leads to end stage kidney disease, which is a place when the patient may require transplantation. So, the diagnosing the patient as having end stage renal disease is important. It is important from the treatment point of view. Pathophysiology of CKD. Initiating mechanism. So actually what happens is when a patient of CKD is there, all the nephrons are not damaged. Some are damaged, some are normal. So the damaged nephrons will not function, whereas the undamaged or otherwise normal will be forced to do more function. They'll be forced to do more function in the form of hyperfiltration, leading to hypertrophy of the wire. That means there is a load, extra load given to the normal nephrons. So when these nephrons suffer from extra load, they develop into damage later. They also get damaged. So this short-term adaptation of hyperfiltration, hypertrophy of the to maintain GFR becomes maladaptive. In fact, it becomes more problematic later. So there is a distortion of nephron architecture and further worsening of kidney function. later. Hmm? So what are the risk factors for CKD? Small gestation at the gestational birth weight. At birth, if the weight of the baby is small, it suggests that the number of nephrons may be less in the kidneys. So these people are prone to develop CKD in later life. That's what. Childhood obesity and hypertension. This hypertension damages nephrons over longer period of time. So if the person is developing hypertension early, he is the more prone to develop kidney CKD early. That's all. And diabetes mellitus, it is one of the important causes of CKD, and this more cases, autoimmune diseases, advanced stage. You should always remember the nephron number decreases with age. So does GFR also. So young person will have 120 ml per minute GFR, whereas a old person may have around 60 to 70 ml, which could be normal for him. So in young people 120, whereas in old it is like this less. So with age, normally the kidney nephrons or GFR comes down, and if these people get if they, for example, if they take some drugs or if they develop diabetes, the chances of progressing to CKD increases. That's what. African ancestry, they are prone for CKD. A family history of kidney disease, if it is there. Presence of proteinuria, yes, one thing. Proteinuria, if it is there, it is a suggest possibility of CKD in later life. Always know that. Not acute, I'm talking about. Acute. Proteinuria can also come up with urinary tract infections. And it disappears once the urinary tract infection goes. But if it is persistent, even after that or without urinary tract infection, then it becomes a risk factor for CKD. Likewise, urinary abnormal sediments are also chance suggests that risk factor. Structural abnormalities of the urinary tract. If, say, for example, one kidney, single kidney, single kidney, ureter malposition, malposition, strictures, and all these things, they can be associated with the CKD later in life. Because if there is a structural problem with the renal system, even the nephrons, number of the nephrons in such a patient may be actually less. And if the patient develops a repeated episodes of acute kidney disease, then these people are prone to develop CKD later. More than multiple times if he develops AKD, although AKD improves over short time, but if the patient suffers from repeated episodes of acute kidney injury, they are prone to develop kidney disease later. And there are some rare inherited forms of CKD, autosomal dominant. There are polycystic kidneys. These patients, young patients can develop CKD here. This has got a very high penetration. So when you discuss a autosomal dominant disease, we always look at penetration of the penetration means the number of people with this autosomal dominant gene developing disease. This autosomal dominant polycystic kidney disease has got 100% penetration. Almost all of them will develop this disease. So it is one of the very good, very bad. And West African population, they are focal segmental glomerulosclerosis, they are prone to develop CKDs. GFR and age. I just not discussed about GFR and age. Normally with age, there is a decline in the annual GFR. From the peak of GFR 120 ml per minute per square per 1.73 meter square attained during the third decade. There is a decline 1 ml per minute per year. Like that. Like this. So when you reach at the age of 70, 70 ml becomes normal. You should know that. So the older people normally will have lesser GFR. So they have got a high risk of developing CKD or may also acute kidney injury if you are giving them some drugs which could be toxic to the kidneys. So old people, be careful about giving drugs which can cause kidney damage because by default their GFR is down. Hmm? And men versus women, women have got a lower GFR compared to men. See, at the age of 70 and 80s, the woman will have 50, whereas men will have 70 ml. Measurement of albuminuria. See, the actually albuminuria is a 24 hours monitoring because the albumin excretion varies from diurnal variation is there. By it is actually to be done over 24 hours and collected and measured. So this is a very cumbersome. Instead, practically albumin creatine ratio is used to check albuminuria. Preferably, first morning urine samples are taken for this USER. About 17 milligrams albumin per gram of creatine. Creatine is creatine in the blood. 17 mg albumin per gram of creatine in the men, and 25 mg of albumin per gram in mg per gram creatinine in woman. It suggests a significant albuminuria. That's what. Early detection of primary kidney disease, systemic microvascular disease. Yeah. See, this microvascular applies to diabetes actually. Diabetic patients are prone to develop microangiopathy, which can cause albuminuria. And later on, it causes to diabetic. See, diabetes has got two types of complications: microvascular and macrovascular. So macrovascular are retinopathies and diabetic nephropathy. Whereas macrovascular are coronary artery disease, heart attack, stroke. These things are macrovascular. So these microvascular diabetic complications will produce microalbuminuria. And later on lead to diabetic nephropathy. This is the way you grade the kidney disease. See here, persistent albuminuria categorizes description range A1, A2, and A3. Normal or mildly increased, that means less than 30 mg per gram creatinine. Whereas moderately raised, 30 to 300 per mg gram creatinine. Here it is more than 300, severely increased. That's how. So albumin, persistent albumin, how do you check like that? So mild, moderate, severe means less than 30, 30 to 300, more than 300 ratio. Here it is a GFR categorized on the ml per minute per. This is only GFR. That is grade 1, normal or high. GFR means more than 90 ml. This is graded according to the amount of albumin. Whereas this is amount of GFR. So more than 90 is good. 60 to 90 is G2. 45 to less, it is further less GFR. Further less. This is very bad. See, kidney failure, and when the GFR falls less than 15, it suggests actually end stage renal disease. And they'll map these two, and further critical scoring can be done. G5A1 or G5A3 like that. G5A3 you can do. This one is G5A3. These all things very severe form. Uremic syndrome. So when you call it as uremic syndrome, large numbers of toxins that accumulate, water soluble, hydrophobic, protein bound, they are actually charged. Unchanged nitrogen containing non-volatile products are in there. These gets accumulated in the blood. Host of metabolic endocrine. Apart from this, in uremic syndrome, the toxins accumulation, there is Apart from that, there is this hormonal imbalance also. That is thyroid hormone, then FGP323, insulin, glucagon. See, the patients with diabetes, if they develop diabetic nephropathy, the insulin requirement will come down. That is because insulin catabolized or insulin requirement comes out because the insulin excretion or catabolism comes down. That's why the insulin requirement in a patient of diabetic nephropathy. One thing I should always remember, a patient who was taking around, imagine 25-10. This is, I'm talking about insulin. In the morning, he is taking 25 units. In the night, he is taking 10 units now. This patient comes to you with later with episodes of hypoglycemia with the same dose. Now you are puzzled why this patient is requiring lesser amount of diabetes treatment. In case if you find such patients, you should always check kidney functions, because a patient who is requiring diabetes drug, anti-diabetic treatment lesser and lesser without obvious clinical improvement, it suggests there is a possibility of kidney disease which is developing. So, if the patient of diabetes develops a kidney disease, their diabetes more or less sometimes disappears. In fact, a patient who is having CKD or end-stage renal disease, the diabetic treatment is almost not required. But that is not the purpose here, but the kidney is already gone. So diabetic treatment almost becomes nil. The insulin requirements or tablets, whatever diabetes treatment is taking, becomes almost like unrequireable like that. So in uremic syndrome patients, the patient's requirement of insulin comes down, and steroid hormones in these also. And one more thing is this vitamin D3 metabolism and effects on the bone because of this, and parathyroid hormone secretion. Secondary hyperparathyroidism happens here. And apart from this endocrine manifestation, there is a systemic inflammation also here in this patient with the uremic syndrome. So the uremic syndrome patients, there is an accumulation of toxins, there is an endocrinal problem, and there is a progressive systemic inflammation too. And the most important thing that bothers in a patient with chronic kidney disease is sodium retention. Thus, expansion of the extracellular volume overload. Patients get bloated, and there is oliguria. Usually, the urine output comes down. Usually, the expansion may contribute to even hypertension. Yeah, a patient with one more thing. Apart from insulin in a patient, imagine now a patient of diabetes mellitus is there. This patient's insulin requirement has come down, and it becomes a severely hypertensive. It is because of expansion of volume and hypertension going unchecked or becoming more. So diabetic patient developing hypertension or severe hypertension suggests CKD onset there. And usually there is a isotonic blood plasma is isotonic. Sometimes, very rarely, they develop hyponatremia, because this expansion of fluid is in response to the sodium retention, not other way around. Due to that, it is isotonic, but sometimes it could be there could be hyponatremia. It could be because of drugs they give and all that. And apart from sodium problem, there could be potassium. So the potassium, there is usually hyper. See, sodium is usually normal, but extracellular volume is increased. Whereas potassium get increased in a CKD patient. You should always know that. Hyperkalemia is a usual thing. And that happens because of predominantly mediated by aldosterone dependent secretion on the distal nephron. Okay. And apart from that, there is a increase intake, hemodialysis, hemorrhage, water hemorrhage, transfusion of steroid, stored blood cells. These things all can cause hyperkalemia. If you give spironolactone. One funny thing is RAS inhibitors. What RAS? ACE. Yeah, and yeah, renin angiotensin system inhibitors, otherwise called as. These are ACEs and ACE inhibitors. Yeah? Receptor inhibitors, sorry. Angiotensin receptor inhibitors and angiotensin enzyme inhibitors. These two are RAS inhibitors. The examples are ramipril, enalapril. This is here losartan, telmisartan, and all these things. These drugs can worsen hyperkalemia. But in a patient who has got a mild CKD, we do still give these drugs because if they progress, they reduce the progression of CKD. Of course, if the patient start developing hyperkalemia, these RAS inhibitors are to be avoided, but otherwise given very carefully. Spironolactone is a potassium sparing diuretic. So this also can worsen hyperkalemia in a patient with CKD. So the metabolic, apart from this sodium and potassium, there is a metabolic acidosis in a patient with the CKD. The patients can still acidify the urine, less ammonia, and therefore cannot extend normal quantity of the protons. Combination of hypokalemia and hyperchloremic acidosis is often present in early stage. One thing you should remember is in a patient with renal failure, there is a hyperchloremic metabolic acidosis in early stage, whereas in the later stage, this hyperchloremic becomes increased and ion, otherwise normochloric or increase anion gap acidosis. That means there is accumulation of lactic acid, all that the chloride levels will come down during that time. So initially there is a hyperchloremic metabolic acidosis. Later on there is a increased and ion gap metabolic acidosis in a patient with the renal failure. With urine output limited to 30 to 40 millimoles, limited, the anions retained in the organic acid can then lead to, that's what, anion gap, increased anion gap, metabolic acidosis. That's what I'm telling. So to overcome this, you need to do alkali supplementation. That is, possibly alkali supplementation means soda bicarb tablets. They in fact even slow the kidney progression, CKD progression. So how do you treat a CKD patient? CKD patients you treat with fluid, electrolytes, and acid-base disorders. These are things which you come on emergency things. So fluid, if there is a volume overload, then you have to give tube diuretics to decrease the volume overload. And hyperkalemia has to be treated with giving them potassium binding resins. And if the loop diureters are not sufficient to correct the volume overload, metolazone can be given. And apart from that, water restriction is to be given. For for hyperkalemia, dietary restriction. Wait a second. For hyperkalemia, dietary restriction of sodium, that is, avoid fruits and fruit juices which contain more potassium, and use kinetic diuretics, that is, loop diuretics and metolazone, all those things. Potassium retaining medications like ACE, ARBs, products to be avoided. Potassium binding resins in the gut. These will bind the resins in the GIT. Thus, they decrease the level of potassium in the body. And dialysis, of course, to reduce potassium. Sodium bicarbonate will correct the acidosis and as well reduces the progression of kidney disease. It slows down kidney damage. Yeah. Now, apart from that sodium, potassium, and acid one, there is a important manifestation of kidney disease on the bones, calcium and phosphate metabolism. Bone manifestations that could be increased PTH level, osteitis, fibrosa, cystica. This happens due to secondary hyperparathyroidism, and there is a hyperosteomalacia due to vitamin D deficiency. Secondary hyperparathyroidism, which leads to this disease, osteitis, fibrosa, cystica. So declining GFR reduces the excretion of phosphate. It reduces the excretion of phosphate. So retained phosphate stimulates the increased synthesis of this hormone FGP, FGF23 by the osteocytes and PTH, and stimulates the growth of parathyroid gland mass. So this growth of parathyroid decreased level of ionized calcium and phosphate will further stimulate the PTH. So what happens is there is a there is what other manifestation is hyperkalemia and hypocalcemia is there in patients of CKD. So calcium is down and phosphate is more. It will stimulate PTH and this hormone which is also responsible for stimulating PTH, thus leading to secondary hyperparathyroidism. This hormone is secreted by osteocytes. It causes increased renal phosphate excretion. That is basically excretion of phosphate. So this hormone increases the excretion of phosphate, stimulates the PTH, suppression of formation of vitamin D3 at the same time, and increase the risk factor for left ventricular hypertrophy, mortality, CKD, and all that. If this hormone is increased, these things are there. That means the patient is prone to develop kidney heart disease, left ventricular hypertrophy, and death. Hyperparathyroidism and leads to osteitis fibrosa cystica. This is a formation of abnormal osteoid in this. Bone marrow fibrosis is there in that. In advanced stages, formation of bone cyst. Sometimes with the hemorrhagic elements inside. And after hyperparathyroidism, bony pain, fragility, brown tumors, compression syndromes, erythropoietin. Erythropoietin is one hormone which is secreted to the kidneys. It is required for hemoglobin or RBC production. And if this secretion is down, patients can develop anemia. And because sometimes there is a dynamic, sometimes there is a suppression. What happens is these patients will receive treatment in the form of vitamin B preparations. Vitamin D are given, and from excessive calcium supplementation, and from exposure to calcium phosphate binders, high calcium dialysis solutions, there is a suppression of PTH production. This leads to aerodynamic bone disease. This can also be the one of the, of course, there is a hyperparathyroidism, but when you treat them, they can end up with this complication. And chronic inflammation also can cause aerodynamic bone disease. Incidents of fracture and bony pain associated with increased vascular and cardiac calcification. Aerodynamic bone disease will cause calcification. Osteomalacia is because of reduced vitamin D3. Calcium, phosphorus, and cardiovascular system. Hyperphosphatemia is increased cardiovascular mortality associated with the low PTH level, low bone tumor turnover. Advanced CKD, this is one of the lesions they can develop, ischemic necrosis, that is called calciphylaxis. Secondary hyperparathyroidism and treatment. Use of phosphate binders and calcium acetate and calcium carbonate. So to treat second hyperthyroidism treatment is phosphate binders, we give them. One thing you should know, if you give phosphate binders excessively, they can cause aerodynamic bone disease. But for secondary hyperthyroidism, we do give the phosphate binders. It also you have to take calcitrol exerts a direct suppressive effect on PTH. So you can give calcitrol. And also, but hypercalcemia and hyperphosphatemia can happen because of that. Cardiovascular abnormalities in the CKD are ischemic valvular vascular disease, heart failure, hypertrophy of left ventricle. Anemia, just now discussed, it is because of decreased iron uptake. So they need to be given with oral supplements of iron and blood transfusion, or even with this recombinant human ESA can be given. So we'll discuss some MCQs. Tell me which of the following drugs does not cause drug toxicity. Sirisha. So this is a drug, cisplatin. Cyclophosphamide can cause kidney toxicity because they can cause hemorrhagic bladder and all that. So this is a drug. Sirolimus is a drug which is not associated with the kidney damage. Same thing written here, also known as the rapamycin. It is a macrolide actually used in coronary stents. Yeah, it can be used in coronary stents produced by this organism. Side effects are diabetes-like symptoms, lung toxicity, lowered cancer risk, impaired wound healing. A 50-year-old diabetic patient is feeling unwell. On workup, his serum creatinine is 5 and blood urea is 125 mg%. Urine MICR test is positive. Which of the following will be useful for this patient? So this ECG is suggestive of actually hyperkalemia. So if you suspect hyperkalemia, among the possible things, this is not no use. AC inhibitors will worsen. Cardioselective beta blockers are no use. Okay, because there is no tachycardia there, the use only. Amiodarone is of no purpose. So you will have only the available possibility in this case, diuretics. They may excrete beta positive potassium, but however, they're not that good. So the ECG manifestations of hyperkalemia, peaked T waves, prolonged PR interval, widened QRS complex, loss of P waves, sine wave. QRS will become sine wave like this, and asystole. Which of the following conditions typically has rickets with a normal or low calcium, elevated phosphorus, and elevated parahormones, elevated alkaline phosphatase? Now you need to typical as rickets. Rickets means what? Typically has a
Hindrance.
rickets means in a osteomalacia is the one of the manifestation of CKD. You know that, Just now I told you that, But vitamin D deficiency alone, will not have elevated phosphorus, and elevated parathyroid. This is not that, So CKD, because in CKD there is a secondary hyperparathyroidism and hyperphosphatemia with hypocalcemia. So elevated phosphorus, that is hyperphosphatemia, hypocalcemia, hyperkalemia, normal sodium. These are the and acidosis is there. So this is the correct answer. Yeah, written same things here. In vitamin D3, low serum calcium, low phosphate, elevated PTH. Whereas in chronic kidney disease, low calcium due to lesser synthesis of vitamin D, elevated phosphate, and elevated PTH. Dentist disease is a X-linked Fanconi disease of distal carotid tubulitis. Triad of saturin, gout, hypertension, renal failure is seen in saturin, gout is seen in lead nephropathy. Lead toxicity actually. The lead toxicity will produce, apart from gout, they can develop with the anemia actually. Anemia which is a microcytic hypochromic anemia with a basophilic stifling. These are can be MCQ. And they also produce peripheral neuropathy. So they produce this picture. Saturn gout, hypertension, and renal failure. That's one of the classical of that. Yeah, I think so. in kidney damage is the proximal tubule. Which of the following statement is on microalbuminuria is not true? Cannot be detected on a routine lab test. So routine lab test is usually dipstick. Huh? Can not true means you have to look for false answer. Cannot be detected by one routine lab test.
True.
Urine protein less than 30 to 29 to 210 micrograms per day is called as microalbuminuria. Microalbuminuria is the independent risk factor for cardiovascular risk in diabetic patient. Microalbuminuria is the earliest marker of diabetic nephropathy. So these two are definitely correct. So you're left with these two. So and cannot detect a routine lab test. Yes, if you are using your dipstick or regular boiling urine, you may not pick it up. You will have to do a special test. That is microalbuminuria test. So this answer, this are correct. You are left with this. Why this is wrong is because he has put in urine total protein. It is microalbuminuria specifies albumin excretion because even globulins and all Tom Horsfall protein, many things can come in the urine, but specifically you have to look for albumin. So this is wrong in this because of that. Yeah, interesting. See, this finding of albumin in urine is not detected by dipstick, the sensitive protein. More than dipstick test, which is usually done, it is more than 1 gram excretion is required here in that. It precedes the decline of GFR, indicates presence of a renal and a cardiovascular complication, marker of increased cardiovascular morbidity and mortality and diabetes, control of sugar BP, ACE, will produce a progression. So how to categorize microalbumin? So see, if you are checking a 24 urine albumin by elaborating method 24 hours all that. So if it is less than 30 ml, 30 mg per 24 ml, it is normal. By dipstick test, you can't pick it up only. Whereas if you're taking spot urine, then you have to look for urine. What is this? Creatine ratio. Albumin, urine albumin, and creatine ratio. Huh? That is in if normal is less than 30 years. That's both the cases. So when you call it as a Michael, when it is between these two is between 30 to 299, 30 to 299. Clinically significant more than 300, more than 300, and in this can become positive with dipstick. So dipstick text only pick up at the when it is very severe. So this is when at the level of preventive stage, dipstick test will not pick it up. We'll have to better do this test. This is the best one because 24 hours urine albumin is a very cumbersome procedure. So this test is done instead. All of the following may result in polyuria except. So hypoaldosteronism, hypercalcemia, lithium carbonate. As I told you, in a chronic renal failure, it is oliguria. Huh? Huh? Oliguria. Hypoaldosteronism will cause what? Adrenalism will cause what? Polyuria. Hypercalcemia because there is a lot of calcium which needs to be excreted. There is a polyuria. Lithium carbonate will cause diabetes insipidus. So because of that, it causes polyuria. So the correct answer is this. Yeah, let's see. Salt wasting polyuria, hypoaldosteronism, hypercalcemia, lithium carbonate. Regarding adult polycystic kidney disease, which one of the following statement is not correct? So it is autosomal dominant with 100% penetration. Yes, often associated with the hepatic cyst. Yeah, associated with the increased incidence of suborgan hemorrhage. Renal carcinoma is a frequent complication, frequent association. What do you think?
Option 2
Huh?
not correct.
What?
Second option,
You are thinking second option. Why?
I think it's not associated with hepatic cyst.
Huh?
hepatic cyst or
Renal cell
absent.
carcinoma it is answer. Because these patients will have what? See, renal cell carcinoma written. These patients will have berry aneurysms, hepatic cysts also. Adult dominant, berry aneurysms is there. They cause subarachnoid hemorrhage because of that. So because of that, hepatic cysts are also known. So renal cell carcinoma doesn't happen. Hmm? Okay.
Okay, sir.
Where I went? Okay, then I'll go to next slide. Which of the following is not a feature of chronic renal failure? See, hyperparathyroidism happens. I discussed just now. Osteomalacia happens. Decreased level of vitamin D3
Option
happens. So
3.
hyperthyroidism is not a feature. Hmm? Okay.
Okay.
Patient on insulin in CKD stage 4. What is the dose adjustment of insulin request? Increase insulin, decrease insulin, normal insulin, add DPP4 inhibitors. As I told, decrease insulin.
Decrease insulin.
Yeah. So all are true about GFR except 30 to 40% decrease after 70 70 years of age. Yes, because 120 it becomes 70 ml. So 30 to 40% it comes. Okay. Best estimated by creatinine clearance. CKD is defined as uh, GFR less than 30 ml per minute, 175 for 4 weeks. For 4 weeks. Hmm. GFR is dependent on height of the different height in children. What do you think? See, it's not 4 weeks, it is a longer time. Okay. Hmm. So 30 to 40% is correct. That's estimated by the creatinine clearance is okay. GFR. Okay. GFR is dependent on height of children. So the answer is CKD is defined as this one. That is wrong. The most common neurological disorders seen in CRF patients: dementia, peripheral neuropathy, restless leg syndrome, and encephalopathy. All of them can happen. This one is more common, peripheral neuropathy. Okay, this is the restless leg syndrome. Encephalopathy because of a metabolic disease they can develop. Metabolic, that is basically they can develop because of that. Dementia can happen. It could be even secondary to hypertension. All that. Peripheral neuropathy is one thing. The term end-stage renal disease is considered when GFR falls below 2. Yes, less than 5 to 10 ml. Concerned. That is less than 15 ml. Otherwise, patient with the CRF is having sodium level of 110 milliequivalent per dl. Till what level should serum sodium should be corrected in next 24 hours? See, if you have got hyposodium or more sodium, your correction should be slower actually. You should not go very aggressively. It can cause problems. Like neurological demyelination and all that. You can go up to 120 milliequivalents. Not seen in uremic lung, alveolar injury, pulmonary edema, interstitial fibrosis, fibrinous exudate in lungs. This one. Interstitial fibrosis is not a feature of that. This can happen. Alveolar injury can happen. Diagnostic feature of CRF is broadcast in urine, elevated urea level, proteinuria, bleeding diathesis. It is except, sorry. Broadcast is not a diagnostic feature of CKD. So elevated, these things are correct. Sorry, yeah, I'm very not accept. It is correct. A diagnostic feature of the CRF is broadcast in urine. This is correct. Sorry. It's not accept. It is correct. So if you can see the broadcast in urine, it suggests chronic renal failure. If you can see. Which of the following study is more sensitive for detecting diabetic nephropathy in early stage? Well, yeah,
Microorganism.
good, very good. CRF shows all except. So there is a hyperphosphatemia, correct? Hyperuricemia, correct? Decrease half-life of insulin, yes, correct.
Increase of life.
Correct? Decrease or increase half-life? Because insulin requirement comes down. Huh?
Decrease.
Yeah, it is
Yeah,
increase.
saturated.
Yeah, decrease serum
Okay.
storage. So insulin requirement comes down. That is because there is increased half-life of insulin. Hmm? This is the answer. Clinical features of CRF bar uremia appear when renal function is reduced to 50%. CRF changes are all except. So hyperkalemia, hypophosphatemia, hypokalemia,
Can be
hypo.
hyperphosphatemia.
There's a mistake here. Why I done this? This is wrong. Twice are written. But whatever it is, hypophosphatemia doesn't happen CRF. It is hyper. Hmm? Hmm? Hypokalemia can occur because of treatment. Raised PTH is found in pseudo hyperparathyroidism, renal osteodystrophy, hypercalcemia, osteogenic imperfecta. Raised renal osteodystrophy. Yeah, secondary hyperparathyroidism is there, na? Because of that. An adult patient present with a normal or enlarged kidney with a massive proteinuria most likely causes. So the adult patient is present with normal or enlarged kidney with a massive proteinuria most likely causes chronic pyelonephritis, chronic glomerulonephritis. These two will cause shrunken kidney. Amyloidosis, renal stenosis. Renal stenosis will cause reduce small kidney. So,
Amyloidosis.
amyloidosis. Chronic pyelonephritis is called scarred and shrunken kidney. Chronic glomerulonephritis also will cause shrunken kidneys. Renal stenosis will cause irregular shrunken kidney pyelonephritis. Regularly shrunken kidney glomerulonephritis. Okay. Renal stenosis because of ischemia there is small kidney. This amyloidosis is a correct answer. Thank you. So, if you
Thank
got
you,
any
sir.
doubts, you can ask me now.
No, sir. No, no,
No
sir.
doubts. Okay then, Hmm?
Thank you, sir.
Okay. Pulkesh?
Yes, sir.
We'll call the day.
Yes, sir. Sure, sir. Thank you, sir.
Okay.